being recorded.
Good afternoon, everyone. We are running into some technical difficulties and haven't been able to get Charlie on the line to kick us off. So I volunteered to blindly step in and start it. If everybody could use their phone or line through their computer, that would be really helpful since we are having technical difficulties. I know people are trying to figure out whether they can be heard or not. We just wanted to get started. I'm going to assume I have control of the slides, and I do, it looks like. So we're going to start, and then Charlie will join us when he can. And just hang with us as everything else in 2020 throws us curveballs, so do webinars. So good afternoon, everyone. My name is Melissa Bailey. I'm actually the Director of Behavioral Health and Child Health Transformation at the Center for Healthcare Strategies. I was planning on being a presenter later on in the slide deck, but we'll kick things off and welcome you to InCK's Child Healthcare Transformation and Early Childhood Policy, Opportunities for Impact and Equity. This webinar was put together by the InCK National Resource Network with the resource partners. And we're going to hear from a couple of different experts today on things related to child health and child health equity. Child health is a state of physical and mental, intellectual, social, emotional well-being and is not merely the absence of disease. I think we all know that child health, especially in the early years, is a really important entry point into working with children and their families to make sure that we're developing the most healthy child and healthy families as possible. InCK's webinar agenda will include beginning remarks from Martha Davis from the Robert Wood Johnson Foundation, who is a funder of InCK. We will hear child health care transformation opportunities in Medicaid and CHIP, with Charlie hopefully weighing in on some of that, but Elizabeth Burke from Georgetown Center for Children and Families, Myra Alvarez, the Children's Partnership, and Myra, I hope I said your name right this time, and myself, Melissa Bailey. We'll also touch on opportunities for federal leadership in transforming child health with Karen Howard and, sorry, but my slides are being covered up by different things just to add to the fun of today. I can see Lombardi, but I can't see the first name.
Joan.
Joan, sorry about that.
Joan Lombardi, can you hear me now?
Oh, there's
Melissa.
Charlie. I can, Charlie. I just started us off, Charlie, but absolutely, I will turn it back over to you.
Yeah. Well, thank you very much. Thank you, Melissa, for going through the first couple of slides and getting up to our introduction of Martha Davis and her presentation. Very delighted to have you all here. I can't see the slides myself, so someone else will have to advance them. The slides will all be available, and the slides for the first webinar are available on the InCK's website. This webinar is scheduled for 75 minutes, but we'll be trying to get through the presentations and commentaries by the end of the hour, and then have 15 minutes for discussion and questions. So please feel free to use the chat box. We have a terrific group of commentators and ones who've been leaders in the field of child health care and early childhood systems building, as Melissa said, and I'll only provide brief introductions as they come up. When planning this webinar, I worked closely with Kay Johnson, who also partnered in developing many of the slides and brainstorming and securing commentators, and we were excited that all our first choices said yes. What distinguishes these commentators is their expertise and passion for improving the lives of children and their backgrounds that really have extended from frontline practice and community to the state and federal levels, and at least in Joan's case, internationally. And this cross-system and frontline to top-line perspective really is needed as we work to advance child healthcare transformation. To lead us off, Martha will describe how this work fits into the RWJ agenda and its emerging emphasis upon equity as a driving force. She joined the Robert Wood Johnson Foundation in 2014 and serves as a key link between RWJF's Children and Families and Healthcare Transformation divisions. And prior to coming to RWJF, she was the co-founder and executive director of the Institute for Safe Families, a Philadelphia nonprofit organization to address issues of family violence and child abuse. And she has certainly moved much beyond that in her work, but I really want to invite her to give us a great kickoff for this important webinar as we move from our prior webinars working on the issues, all the detailed issues around practice transformation, to the issues around what can we do in terms of policy that will affect that practice transformation.
Thank you, Charlie. You know, you can tell you've been at it a long time when the picture they flash up has you as a blonde and that my hair is silver. So let's just say some of us have been in this for quite some time. And let me just start by saying thank you so much for joining us and being on this webinar. And a big thank you to the National Advisory Board and Kay Johnson and Charlie Brunner for your steadfast leadership with this network. We started funding RWJ in 2018. And, you know, really in this time where we've just had so many overlapping crises, they have provided smart, responsive, compelling leadership to advance both child health systems transformation and child health equity. So Charlie asked me to say a few words, and I'm really happy to do that. And I also feel just honored to be on this panel with so many people that I have learned so much from and really follow your work. So thank you. So I love this quote by Nelson Mandela. But the truth is, so many of the systems that children and their families interact with right from the start are systems of oppression that create poor outcomes. And too many children and youth do not have access to services and community conditions that would ensure their optimal health and well-being over their lives. And really, even before COVID, nearly 1 in 6 children were living below the poverty line, and nearly 73% of them were children of color. Uh-oh, go back, too fast. Whoop. Actually, I have control of the slides, I think, or maybe I don't. Anyway, and about 1 in 3 Black children, 1 in 4 Latinx children were poor in 2018, compared to 1 in 11 white children. So we know, everybody on this webinar knows that profound inequities exist by race, place, social and economic status. And children of color are more likely to be poor, on Medicaid, face environmental hazards, and live in communities where there's major disinvestment. So we are focused on this vision. This is really our vision for children and families, that all families have the resources they need to foster healthy development of children. And we have a particular focus on children and their families who are most overburdened and furthest from opportunity, and those who have experienced long-standing structural barriers to opportunity, whether it's in healthcare, access to high-quality childcare, a lack of nutrition, or a lack of income supports that allow families to flourish. So we're also seeing major and what will be long-term impacts of COVID on children and their caregivers. And a point about caregivers and why we're really focusing on not just children but their families is many of these caregivers are called essential workers, but COVID-19 has really shown that the very people that we rely on are not those who receive the most investment, and that while we may see them as essential, we herald them as heroes, we really don't treat them that way. I also just want to point out that there's lots of amazing work that's happening despite COVID-19, and we heard on a previous webinar about how child health practices are innovating and pivoting in these challenging times. So very impressed with this work here with InCK. So I'll just say a little something about our approach towards children and families at the Robert Wood Johnson Foundation. We know that to create equitable opportunities for families and their children, we need a robust set of strategies and approaches that will address the broader social and economic circumstances that make it so difficult for many families to fulfill their aspirations. And these strategies include work to actively change mindsets, advance a range of policies that support families, and thirdly, transform the kind of care that children and their families experience. And specifically, we're focused on transforming the child health care system so that children and their families are treated as whole people with a set of interrelated needs and goals and aspirations. And what we're really talking about here is a system that would be transformed and not merely fixed or tinkered around at the edges. I'll just say a couple points about mindsets. We believe that there needs to be this shift in this idea of really deservingness. We've been doing a lot of exploration about what are those key mindsets that drive decisions. And one of them seems to be deservingness. We know that policy decisions are get made are rooted in this idea of deservingness, and that we need to reinforce this value that all caregivers and parents deserve support. We also know that government action or inaction has a direct role in whether or not families prosper or suffer. So school meals, Medicaid and health policy shifts, childcare subsidy changes, unemployment insurance, all of these matter. And you're going to hear on this webinar from just a great lineup of folks, Elizabeth, Karen, Myra, Melissa, and Joan, about some timely opportunities to advance federal policy. So I'm very proud of the work that we have supported. Starting in 2016, the Health Equity and Young Children Initiative that many of you were a part of, we've supported this network, and now we're supporting the Center for Healthcare Strategies under Melissa's leadership to do even more. And you'll be hearing more about that. So it's always a little risky to put up a draft on a national webinar, but why not? So this is a draft set of core values. It's really informed by many of you on this webinar that really sets forth a vision for transformation. And it's really at a number of levels, whether it's the practice, the system, even the larger social context. But we think these need to be at the foundation of any transformed child health system that serves children and their families, whether it's responding to the whole child and family, or to the way that child health systems connect with other early childhood systems, or working to address, mitigate, and even dismantle systems of oppression, particularly racism. So I'm very hopeful that the child health and other early childhood systems can lead this charge. There is so much great work going on, whether it's the Center for the Study of Social Policy, our friends at Georgetown, our friends at First Focus, the work with the InCK networks, the efforts of Help Me Grow, the pediatric supporting parents work. There is just so much agreement in what we can do moving forward. So we look forward to advancing this work with many of you, and I'll pass it back over to Charlie. Thank you.
Well, thank you very much, Martha, and I really appreciate the work and of the Robert Wood Johnson Foundation and really building a culture of health that really is equitable and does respond to the needs of children and families, and really moving towards a child health care system, not just a child medical care system. And this slide just reiterates what Martha was saying, that one of our problems why transformation in child health is essential to achieving equity is many children don't have access to services and communities needed to ensure optimal development. And we're really talking about at least 1 in 4 kids are not developing optimally in the United States, and disproportionately this is among children of color, and there are inequities by race, place, and socioeconomic status. And children of color are more likely to be poor on Medicaid, face environmental hazards, live in disadvantaged communities, and have the added burden of racism. And child health transformation is really essential to help shift these negative social determinants, confront racism, and rectify inequities for that population and for our country's future well-being. And that is the basis of our work. InCK's mission and partnership in this slide really just shows we're really supporting leaders in the field to advance this child and youth health transformation, which involves really working with our 35 national partner organizations for their great work. And what Martha said, that there are a great number of people who are working and organizations who are working towards this transformation of the early childhood system as a whole and the child health care system specifically. The InCK network itself and our national advisory team have defined the elements of child health care transformation as involving practice transformation, which is really around establishing at the primary and preventive and promotive health service practice level, family-centered medical homes that are embedded in the communities they serve, with resultant metrics transformation that really does measure how well those systems identify and respond to the whole child and social as well as biomedical determinants of health, and how the finance system supports practices which move forward to do more in the way of providing comprehensive health services and not just medical services to treat medical disease and injury. And this really all is, and I think this is also reflected in Martha's slides around RWJS, it really is a mindset and a cultural transformation that really is children, youth, and family-centered care that emphasizes optimal health, development that goes beyond physical development to social, emotional, behavioral, relational, cognitive, and language development, and overall well-being from an equity perspective. And we've done our prior webinars to really go into detail on what this means in practice. I'm sharing this next slide, which you probably cannot read, but is, I think, just shows that increasingly people who are working in the field of how do we improve results for children and young children are recognizing health as one of the core components, not the only component, but the core components. So the National Collaborative for Infants and Toddlers, really, which is from the CRISPR initiative, has health along with family support and early care and education as three core elements. The Aspen Institute's focus upon two-generation strategies really are focused upon health and well-being. 0 to 3 in class have come together around what babies need 0 to 3 and included health as a component. The long-standing early childhood development system framework developed with Bill and many others in the field with the different ovals had health as a major oval. And the Robert Johnson Foundation framework for building a culture of health says it's health, care, it's social services, and it's public health. But in each of these, health is a major role a critical role in developing a robust overall child health system and an early child health system. And clearly, it plays a particularly important role, as this slide shows, in terms of early childhood systems, because birth through 3, the primary care practitioner really is the one near universal point of contact with children and families, and moreover sees the child and family multiple times in providing a continuity of well child care, that we have a growing array of exemplary practices which really all move to being high-performing medical homes that show the value of this transformation, and when it responds to the whole child and social determinants of health, in terms of improving both the outcomes for the child and for the family environment that leads to long-term health benefits. And third, that the professional field really recognize and support this transformation. It's in the Bright Futures guidelines developed by AARP and HRSA that govern well child visits. It's in the principles of a pediatric medical home, and it's in the life course model for health. So we really recognize when we're looking at the early childhood space that child healthcare transformation and really building a robust child health system that extends to respond to families and communities and not just medical care needs is critical. We also know, and this slide provides that framework, that Medicaid plays the core role for these children, and particularly for children of color. In 2018, according to ACS data, Medicaid and public programs covered more than half of all children, not just children 0 to 3, but all children identified as Black, Latinx, Native American, and Alaskan, and multi-race or other. And there are different ways of calculating it, but for children 0 to 3 overall in our society, somewhere between 44 and 55% of all kids are enrolled in Medicaid. And the next slide really leads as a segue into our first set of presenters, that because of this, Medicaid can finance this child health care transformation and must play a key role in doing so. And certainly the Medicaid EPSDT benefit is designed to provide this financing. Both the Center for Healthcare Strategies and the Georgetown Center for Children and Families were involved with other leading organizations in the birth to 3 space and the child health space to produce a set of consensus opportunities for Medicaid to improve young child health, and focused on really saying Medicaid can play a key role by ensuring enrollment of coverage of kids, preventive primary health care services, screening and responses to social as well as biomedical determinants of health, providing care coordination and linkages to community resources, to provide an expanded EPSDT, use the EPSDT benefit scope to really augment the services that are available, to produce more integrated systems, and to really create a value-based payment system that really does support practices as they move toward high-performing medical homes and high-value care. That really does lead in, and we'll go into more detail of this, to the first commentators who can really speak to Medicaid and young child development. Elizabeth Baraka is a senior fellow at the Georgetown Center for Children and Families and really leading their work on Medicaid and young children, including working with multiple state leaders on the Packard Foundation's Finish Line project. She has more than 2 decades experience at the state and national levels in child policy, coming to Georgetown from Arkansas Advocates for Children, where she led many of their successful policy efforts to expand child health coverage and content. Melissa Bailey is the Director of Behavioral Health and Child Health Transformation at the Center for Healthcare Strategies. Her areas of expertise include systems reform and integration of physical and behavioral health. And prior to joining the center, Ms. Bailey was the commissioner for the Vermont Department of Mental Health, leading service delivery and payment reform, development of new programs, and quality improvement and oversight for states. And really, Vermont has been at the cutting edge for child health transformation. She really brings that experience from doing it on the ground as well as at a policy level. And finally, Maria Alvarez is the president of the Children's Partnership, a nonprofit advocacy organization of children committed to giving every child, no matter their background, full opportunities to succeed. And she is working at the partnership to advance child health within the state of California, which is really on the cutting edge of doing much of this work. But prior to coming to the partnership, she had several years set of assignments at the U.S. Department of Health and Human Services, including serving as the Associate Director for the Office of Minority Health, where she led coordination of that work related to the Affordable Care Act, community health workers and language access. And prior to joining the administration, she served as a legislative assistant for Senator Dick Durbin, and before then for former Congressperson Hilda Sola. So I'm really delighted to have these 3 leading thinkers and doers in the field around Child Health Development and Medicaid to provide their perspective. So I'll turn it over to Elizabeth.
Oh.
Can you get on, Elizabeth?
All guests have been unmuted. All guests have been muted. You can unmute your line by pressing *6.
Oh, can you all hear me? Okay, I cannot hear you, so I'm just gonna roll with it. Forgive me, I think my phone connection died just as, I guess, Charlie started me. I'll just look for hand signals if I stop, if you can't hear me anymore. So thank you so much for letting me be part of this conversation. It's an honor to be with such a rock star group of folks. And I will just say, you know, I'm going to try to keep this pretty big picture because I think Melissa and Myra can really get into some more of the details of what this might mean at the state and the practice level, which is frankly from a Medicaid and CHIP policy place where we try to learn and where we've been fortunate enough to learn as we go. I'll just start by saying I would be remiss if I didn't just mention some of the hurdles ahead of us at the federal and state level right now, that there's a lot to overcome. Even before COVID became sort of crashing down on us in 2020, we just saw updated census numbers on the rate of uninsured children in 2019. Again, a significant increase in young children and children, and we're going to put more of those data out soon. Significantly Latino children, especially who are already one of the highest groups of uninsured kids. You know, coverage itself is not what we're here to talk about, but it is the price of admission. We also want the show to be good. We want this transformation to work, but we got to get them in the door. So that's number one. We also know yesterday, and I put all these links in the chat because of course I didn't make slides and all this stuff came out in between. The second is that federal Medicaid put out some data yesterday about utilization of basic healthcare services, vaccinations, preventive primary care, mental health, dental. We've seen significant decreases, as you might expect, compared to last year in terms of kids getting those services. So we really, just getting the basics is an uphill battle right now. And the biggest thing that could happen to help, you know, we had a COVID relief package that increased the federal matching rate for states back in March, which feels like both forever ago and yesterday. That was not nearly what we saw during the last recession. It was about half that point, and Bruce is on, so he can correct me if I'm wrong. But you know, we really need to see, and there have been proposals to up the FMAP and increase that fiscal relief. That's just to get us back to sort of where we are, so states don't have to be forced to make decisions about what they're going to cut, which would be essentially rates and benefits. So that is the not helpful. I want to just kind of lay that out there as a basic. But I do want to talk about, I do think there's a lot of innovation. What I think is an opportunity here is to think about, you know, we are all seeing the stress on our families. The work that Joan Lombardi and the surveys on young children and families have looked at the real day-to-day stress happening for people we all know and can see. We're all experiencing stress in some way, and I'm hoping that that's an opportunity for us to really rethink how we do business for families. And that Medicaid absolutely needs to be a part of that, and rethinking how our health system responds to kids' needs. So I'm just going to lay out some big picture thoughts based on a paper we did a few years ago about what can Medicaid really do for young children. A lot of this is state-based. A lot of this is about administrative advocacy at the state level, which is just not as easy as a legislative at the federal level fix, but really, really important, which is both the challenge and an opportunity. The first is, again, and thank you, Martha, sort of laid this out really well. Adults and caregivers matter. We cannot think about how we're going to help kids most if we're not thinking about their parents and other adults. And so states that have an expanded Medicaid, that's a number 1, 2, and 3 thing we say. And even those that have the kinds of things happening now, like extending postpartum coverage, other things that are going to have not only an impact on those parents, but also their young children well into their later years. We just cannot look at kids anymore absent everyone else in their lives. And folks like us have known that for a while, but it's important that we continue. I love that Martha and the Robert Wood Johnson Foundation are thinking about this undeserving versus deserving. We've got to figure out a way to really think differently about that. The second, as I just alluded to, is kids all need consistent, continuous health coverage. We've got lots of gaps. Kids are falling off. Usually it's the majority of uninsured kids are likely eligible for Medicaid and CHIP. So things that states are doing, like continuous eligibility for at least a year, is, again, really important. And it's not just, for the purposes of this conversation, it's not just keeping them on, which of course is important, but if a kid is on for at least 12 months or more, we get much better data on quality. They don't even go into the quality data if they stay on for shorter periods of time than 12 months. And so we need to make sure, if we're doing our due diligence on measuring what's happening with kids, that they're already in and consistently covered. And the third, Charlie and I talk about a lot, and he referenced that we have not realized the full potential of Medicaid's pediatric benefit. EPSDT, early periodic screening, diagnostic, and treatment, or someone said the other day to remember the acronym, it's every president should just rotates. Use what acronym you want. But that is really, we know it on paper, it is incredibly important benefit for kids. It has prevention baked in. It is the gold standard. We're not living up to it. And so really, that Charlie's right. Nothing in these InCK innovation grants, there's a lot of things happening that are completely doable with a little elbow grease already. And how do we really make child development the center of what our knowledge base is about kids and their healthcare and their development? And part of that is much more transparency and accountability in managed care data and outcomes. Most kids in this country in Medicaid or CHIP are in managed care plans, and getting information that's reported and transparent and consistent is incredibly difficult. It wouldn't seem like that, but folks, and Myra might talk about in California, they've done a lot of unpacking what's going on in terms of data, but really understanding what's already happening so we can go beyond that. Fourth is sort of just, we need to fund research-based interventions that we know work. And Charlie's great at saying this a lot too. We know it works. We need to fund it. And things like maternal depression screening for moms and making sure they get treatment, that matters for kids. Things like Healthy Step and team-based care and pediatric practices. We have to change the way we're addressing and meeting families' needs at the practice level. And along with that, our fifth, we always say, is we need to invest, and states need to invest in particular, in prevention and innovation. A lot of states are looking at different payment models in Medicaid. Value-based payment is the term of art that we all use in the healthcare system. And sometimes with the wrong audiences or those that aren't thinking big picture, value-based payment or even alternative payment models can mean, how do we save money? And for kids, we're not going to save money. Arguably, we should be spending more money because they're already really inexpensive compared to the long-term care and adults in the system. So what I think is the most important thing for any of these conversations is making sure that folks with child development expertise and advocates for these families, and that, whether it's organizations or families or others, need to be at these tables, even though they can be really complicated, and be there to say, hold on, this new payment model, what's it going to mean for kids? They need something entirely different than a 35-year-old with a chronic condition. So to me, that's the most important opportunity. We need to get in there and help understand that this might not be about saving money in the short term, but definitely in the long term across all systems. And finally, I would just say, Medicaid, we all know, can't do this alone. Tremendous opportunity, and I would argue we need to do more, but we also know all these other systems that touch kids. We need to connect those dots better. And I know, for example, Kay Johnson is finishing up a piece with the Pediatric Supporting Parents Project really outlining the requirements in statute, both for Medicaid and Title V and public health agencies, and what those agencies are supposed to do. And when I say Medicaid can't do it alone, I mean that in terms of money, but I also mean in terms of expertise. You know, Medicaid folks are payers. They are not necessarily child development experts. How do we leverage those other systems to help be those experts to get the job done? And so with that, I'm sorry I cannot hear you. I will try to work on that, but I appreciate the opportunity to be part of this conversation.
Great. Charlie, I'm just going to go ahead and jump in and hope that everybody can hear me okay. Good. So just first, I want to echo a lot of what Elizabeth said. I can't say enough about adults and the grown-ups. I just heard somebody recently describe when talking with kids, rather than calling them their parents or their caregivers, to say you're grown-ups, which I thought was a really nice way to reference the people that are in kids' lives and that are caring for kids. And with that, just thinking beyond sort of the nuclear family, but more of the multi-generational approach and how families are configured differently depending on what works for them. And so just really wanting to think about that. But the one thing that I want to touch on just at the beginning is this idea of transformation and some of the work that we're doing at the Center for Healthcare Strategies, where we're advancing child health transformation. Goes back to something else that Elizabeth said, which is we really do know what we need to do. We need the tools to do it well and the tools to be able to do it consistently, which to me, some of the elements within the Accelerating Child Health Transformation include things like talking about multi-generation and a family-driven approach. Families know their families best, and they know what they need, and they need to have a stronger voice within this arena. We need to think about the multi-generational, which I mentioned before. We need to understand social risk and social needs and how they impact families, and be able to find those resources that are outside the four walls of the pediatric practice and bring those into the practice to be a part of addressing needs and risk for families. And then lastly is really addressing that race equity piece, looking at what practice changes need to happen. And again, not at all indicating that pediatrics alone can solve race equity or health equity as it exists, but they definitely have a role and a voice. And I really do believe that within our system, we need to do the ground up and the top down, and then we'll meet in the middle and we'll actually move things forward. And so being able to have that ongoing conversation, you know, really rolling up your sleeves, figuring out what works, and developing models that allow for flexibility is really important. The other pieces that I think are important in looking at how to really implement things and to transform our system is thinking about those items that Elizabeth also mentioned, which is the value-based payment or payment model. And I want to talk a little bit about some experience that I had in Vermont related to that. Also, how we measure and what we measure is really important. And then just really overarching the culture. We all are sitting on this call because we know kids are important. We know families with young children are important, but we need to continue to really grow that culture within the United States so that everybody is paying attention to this. If we want healthy adults, we start with healthy kids. So just wanting to put those couple of pieces out there to begin with. The one other thing I'll say about EPSDT, every president should destroy tapes. I changed it to every president should destroy tweets because I feel like that's more appropriate these days. So we'll change that. Anyway, I want to talk a little bit about the payment piece. We've been doing some work in value-based payment, and I want to go back to some experience that I had in Vermont, even prior to me being in the commissioner position, where we really changed the payment model to get to a more prevention upstream approach. And our sort of mantra was, we want to get you the money as easily as possible so you can do the things that we want you to do, and we can hold you accountable for doing those things well. And through that model, what we've created were the flexibilities that were needed for providers so that they could get the families in a more upstream way, not waiting until there was a diagnosis on a piece of paper, but actually trying to build capacity and expertise in the more prevention arena. So much so that one of our community mental health centers was able to actually build a resiliency program. So I really do think that money can drive so much of the practice change. We just need to make sure that we're not focusing in on, like Elizabeth said, savings, what we're focusing in on is spending those dollars more effectively. And so I do think that there's a lot of opportunity in the kids' world to spend those dollars more effectively, not just on the children, but also on the adults. Some of the other areas that Charlie had in his slide that were the consensus pieces that I just want to touch on is really about the integration of systems. You know, we in this goes back to the value-based payment conversation, and some of the interviews that we've been doing, it's really been very health system focused. And we hear time and time again that there's not savings in the health system as it relates to kids. And my answer always is, or my response is, yeah, but there is in other areas. So we know that that money is being spent in education, in child welfare, in other social services. And the more that we can create a collaborative, integrated approach to kids and families, the better off we're going to be in not saving those dollars, but again, spending them more effectively. And then I think the last thing that I'll touch on is really the population health piece. I think it's really important that through this work, we're thinking about individual families, we're thinking about children that reside within those families, and it's, you know, it's not just young kids, sometimes it's young kids, and there's also older adolescents in the family, so really thinking about the whole family well-being. But there's also the population approach. There's the way that our system is set up that really supports populations and communities. And so I think parallel to the conversation about what can Medicaid do, what can these systems that serve kids and families do, is also continuing to think about the population health, because we all know that we rise up one, we rise up all. And so we want to continue to think about, again, the sort of individual systems approach that we're tackling, but also from this population lens. And I know I went way over my 5 minutes, so I'm going to stop and pass it along.
Thanks, Melissa. Can you hear me? Oh, good. Okay, I'm getting visual cues. Hi, everybody. My name is Myra Alvarez. I'm president of the Children's Partnership. I'm very honored to be here with you all and provide a couple of thoughts. I know I only have a few minutes before we open it up to discussion. And I want to take us back to some of the comments that Charlie and Martha really started us off with, thinking about child equity and what it means to advance child equity in this time, and really keeping a focus on what's happening in our country and the racial reckoning that we are facing. Racial justice, as a definition, is the systemic and fair treatment of all, resulting in equitable opportunities and outcomes. But one way that racial justice happens is the deliberate enactment of policies to ensure that we're closing gaps in economic and racial disparities. It's deliberate enactment of policies. And you know, something someone said earlier about we need the tools to do it well. I'm here to argue in my 5 minutes that we have the tools to do it well, and that we need the political will to get it done. And I think in a state like California, we have incredible leaders who have prioritized early childhood development. We have a new Surgeon General that's really shining a light on adverse childhood experiences. We have an incredible governor and administration. And I think we have the advocacy community to really push our administration to do right by our children. And I want to say that our approach to this work is a targeted universalism approach, that a rising tide does not lift all boats. And you have to focus on those boats that are broken and that have historically been oppressed. And when you look at children in California, it is children of color that are further left behind. And when you look at our Medi-Cal program, our state Medicaid program, 3 out of 4 kids that are part of our Medicaid program are children of color. Over 5 million children are part of our Medicaid program, and the overwhelming majority are kids of color. So do we have the tools to do it well? Absolutely. And it's the political will. So I think really thinking through these comments, I want to focus on three overarching areas. One, it's those closest to the problem are the ones that have the best solutions to address it. The second one is focusing on a family unit in order to serve children. And the third is the importance of bringing care to the community. So I'll start with the first one and really thinking about those closest to the problem or closest to the solutions. I think we've talked a lot about in this webinar series the importance of elevating a community health workforce and exploring opportunities to give power to community and the contributions that they make to child well-being. And I think here in California, there's a number of us as advocates that are pushing community health workers from any number of different perspectives. You have folks that are pushing a community-based doula model in order to address maternal mortality and infant mortality, particularly in the Black community. A community-based doula are proven to be effective, obviously. And although we didn't cross that finish line for that initiative, it's an important building of awareness regarding a community health workforce like community-based doulas. But you also see it in asthma remediation and the importance of community health workers and promotoras. You also see it in looking at broader health and well-being issues and how community health workers, even during this time of COVID, are helping families navigate systems and the importance of that navigation and care coordination in order to meet their needs. And the overwhelming majority of community health workers, promotoras, community-based doulas, peer support specialists in mental health are people that are reflective of the community. So really recognizing opportunities to utilize Medicaid and pay for the value that this community health workforce is providing is dismantling systems that have not served our families effectively and that better respond to their needs. So really trying to elevate community health workers in order to better respond to the needs of kids. And I want to just a couple seconds on the fact that there's been a number of opportunities to utilize community health workers for adults, namely for chronically ill adults, for addressing chronic disease management, for working with chronically homeless communities. We have a very successful whole person care initiative in California. As child advocates, we're advocating that those same benefits that we are seeing and a whole person care approach for chronically ill adults are the same benefits that we will see with children if we emphasize prevention and early intervention utilizing the community health worker model. So the second one is focusing on a family unit. And my previous panelists have talked about this. We're really looking at ways in which we can consider families as a unit and not a child only. And we've seen some important progress here in California in that the state has made a major step forward in this area by making family therapy for children a covered Medi-Cal benefit, even without a mental health diagnosis. And that is particularly important, again, during this COVID-19 period, where frankly, all children are traumatized. All children are traumatized by the fact that we've been home for 6 months, and that for many of us in California, particularly those of us in Los Angeles County, are continuing to try and stay home, or are continuing to try and do our best to stay home because many of our frontline workers are actually having to go into work, right? Again, disproportionately people of color. But thinking through ways in which we can expand this family therapy benefit and explore other opportunities, whether it's Healthy Steps or others, provides an immediate opportunity for the state to allow these evidence-based dyad models to move forward. And again, consider the importance of family units in order to better serve children. And then the third example that I'll talk about is bringing care to the community. And this is the idea of really looking to accountability and managed care plans to partner with community organizations that better serve families' needs. And I should say comprehensive needs. Others have mentioned, we're not expecting the healthcare system to solve everything, but we're expecting the healthcare system to be connected to the right services that address the family-specific needs. And that is something that our healthcare system can do. So requiring health plans, for example, we're going through an opportunity for public comment on reprocurement of managed care plans. How can we use that process to hold health plans accountable to partnering with community entities that better serve families' needs? That's something many of us are working on here. But also thinking about bringing care into the community that meet those needs. So one of the things that we've been pushing as a result of our work with children and immigrant families is the importance of legal services integration into health settings. If we have a trusted door of a health center, how can that door open up an opportunity to speak to a lawyer or to get a legal service consultation to answer questions about immigration, or frankly, answer questions about tenant rights, about eviction concerns, because that's the majority of questions that people have when it comes to medical legal partnerships. Project Dulce is one that has been successful across the country for children, really thinking again, how can we uniquely serve the needs of families by challenging our healthcare system to be more comprehensive in its approach. We have the tools to get it done, and we need the political will to follow. I just want to close by saying it is quite the year for us, and it's I want to emphasize that it has been a painful year for many communities, particularly Black communities and communities of color. And it is the responsibility of all of us to take this moment and do something different in order to serve children, and in particular, children of color, better. And I look forward to working with all of you to make that happen together. Thanks.
Charlie, are you available? Okay, I'm going to jump back in. Winging it once again.
Can you hear me
there
now?
you go. Okay, go ahead.
I got put on mute, excuse me. Well, thank you for the presentations, and we know that it's going to continue to be important and critical to advance child health care transformation and early childhood systems building at the state levels and at the community levels. And really the federal Medicaid and EPSDT law provides the basis for states to advance child health care transformation. But at the same time, we are going to have a new administration coming in 2021. We are looking at the federal government as probably playing a key role, particularly going forward as states are going to be strapped with their budgets as a result of COVID-19. And the federal government has much more opportunity to put forward with new investments to really look at what can happen and what we can be advocating for at the federal level. And obviously, we have Karen Howard and Joan Lombardi who will provide commentary on that. But I wanted to provide a little bit of context, and I'll go through these really quickly. In the past, we've already had a number of federal initiatives over time which have really worked on the role of healthcare for improving school readiness, mainly through limited or demonstration grants to states. CMS with CMMI and CHIP demonstrations, HRSA with the Early Childhood Comprehensive Service grants and SPRANS grants, SAMHSA with Project Launch, and then DOE and DHHS with the Race to the Top Early Learning Challenge grants and preschool grants. That we've really had a lot going on that has kind of set the stage for further action. The next slide says that there are also some programs that have moved beyond kind of the demonstration program to having a nationwide presence in terms of McBee home visiting and certainly the child welfare services and the movements in the Family First Prevention Act. And so we have something where we certainly don't need to start from scratch at the federal level to address issues around child health care transformation. We also have advocates who are really calling for substantial increases in federal funding in the areas of early childhood. And this has come with respect of growing, I think, support at the grassroots and grass tops level and penetrating into federal policy and action around child care, preschool, home visiting, and family leave. But we really also have an opportunity for the federal government to continue to advance diffusion and scale up of exemplary programs to advance child's health care role in early childhood. And this is something I think that all three of our presenters spoke to before commentators, and what really can provide help to states and encouragement to states to advance child health care transformation. And what we're doing preliminarily, and we really want to work with our 35 national partners and others in the field to really look at what are the federal opportunities for the next administration to advance child health care transformation and really rebuild back better, stronger, fairer, and smarter our early childhood and healthcare systems. And we think that there are real opportunities to provide for further innovation investments through the Center for Medicare and Medicaid Innovations and really have a much larger share of its financing, potentially $2 or $3 billion over the next 5 years, directed toward child health care itself. Most of the funding in the first 10 years of its operation, has been directed to adult populations and not toward primary preventive and developmental health services for kids, but that's an avenue. A second avenue, as far as the federal opportunity, is to really provide increasing elevated federal financial participation, as has been done for in other areas where there's been an opportunity in terms of building data systems and outcome systems really to advance high-performing medical homes, so that rather than the regular federal financial participation rate, really going forward to provide an increased reimbursement when states define high-performing medical homes and begin to move toward delivering health services that are more comprehensive. And the third, and I think Myra talked about community health workers, but that community-based relational healthcare workforce for young children, increased investments through Title V or other block grants to advance that work, because we know that that is one of the things which is exceedingly important to most of the programs that have shown strong results for kids and families, have had that in their arsenal and have invested in that. So federal investments in child health care transformation are needed, commensurate with those for early care and education and family support at the federal level, to really enable states and communities and practices to move from demonstration efforts to really move towards scale and to reaching the population that needs to be served. So now I'd really like to turn it over for our final commentaries from Karen Howard and Joan Lombardi. And just extremely quickly, Karen currently serves as a child equity consultant, but she has just served as Senior Policy Director of the Alliance for Early Success. And prior to that, she was Vice President of Early Childhood Policy at First Focus on Children, and she has also served as Director of Policy of the Nurse Family Partnership, as Legislative Counsel in the Office of Colorado Senator Ken Salazar, and as Deputy Attorney General in Colorado Office of the Attorney General. So she really has a depth of background. Joan Lombardi is a long-standing partner in crime of mine and an international expert on child development and social policy. She has too many current roles to mention, but they really include consulting with foundations, mentoring early childhood leaders across the country and world, and promoting evidence-based programs, practices, and policies. And she served in the U.S. Department of Health and Human Services, most recently as Deputy Assistant Secretary during the Obama administration, including development of the cross-agency Race to the Top Early Learning Challenge grants and others. So really want to turn it over to each of you to present, and if we go over the time frame, that will be okay, but we will try to also have concluding remarks from people after your presentations. Karen? And I hope Karen can hear and maybe unmute herself.
Karen, we can't hear you.
Unmute me. I am by telephone. Yikes. Let's see.
We can hear you now.
You are now unmuted, Karen.
You just remuted yourself.
Oh.
Okay, Karen, you
there
are
you go.
unmuted.
You're good now. Nope, you just muted it. There you go.
Okay, not quite sure.
Okay, you're good. You're good.
Yes?
You're good.
Okay, thanks so much, everyone. So sorry for the technical problems. Thank you, Charlie. It's great to be on this superstar panel. I wanted to start with a quote just to center some of our discussions on racial equity and to mirror what everyone else has said, Myra and a lot of other folks. But the quote from Ibram Kendi is, in 1865, Black people all over the South were saying to Union officials, do not abolish slavery and call that freedom. Do not allow the law to replace the master. Do not abolish slavery and leave us landless and disenfranchised. Do not force us to work for our former masters and call that freedom. Do not call us free if we are enslaved by racism. And I say that because I think it's been well sort of documented on this call. To transform healthcare, we really do need to fight structural racism everywhere that it exists in society, and it permeates every bit of society. I know folks saw yesterday the Kentucky Attorney General announced that there wouldn't be any charges in the Breonna Taylor case. We didn't need another example of stark example of racism, but we got it again and again, and particularly this year, and we have for 400 years. And many people ask, well, what does police brutality have to do with children and families and what we're talking about? It has everything to do with it. It is part of the system of oppression. And so it is state-sanctioned violence, just as insidious as police brutality when children do not have adequate food, when families aren't cared for, with mental health, transportation, housing, all the supports, when they are made to work for minimum wage, right, and then called essential, but in no way treated as essential. And so I say this because we can't look at healthcare transformation without joining the fight in other sectors against societal and systemic racism and really lifting it up. So what's that mean for us? It means that we join the fight with housing advocates. We join the fight to reimagine policing, which is so oppressive to the Black and Brown communities. We do this by joining the environmental fight. And I know everyone knows this, but I think it bears lifting up that these are all our lanes. Our lanes are every lane that impacts children and families in our society, and as Martha and everyone else has said, that breaks down those systems of oppression. We see that happening already. The panelists have spoken to it, but I see that also with declarations by over 20 local entities and some states that racism is a public health crisis, right? And we know that Senator Sherrod Brown from Ohio has introduced a resolution to that effect. And why is that important? It's important that we actually name it explicitly, because only then can we start to tackle structural racism, and only then can we start to address what Martha talked about as deservedness. Deservedness in our country means, in a lot of ways, what you look like and what zip code you come from. And so breaking down deservedness and telling the true history is really important. It's important to health, it's important to education, and that work is really underway, and I wanted to just lift that up. And we know, of course, the American Academy of Pediatrics and the American Medical Association have also acknowledged racism as a public crisis, public enemy number one, and that's the way we have to treat it if we're going to be good allies and accomplices to all of our brothers and sisters in the struggle who are doing this work. The second thing, and I think, Myra, you raised this up really well, and so did you, Melissa, and that is parent and family engagement. You know, the people closest to the problems really do have the solutions. We have seen in home visiting, right, where we were so worried that families would not get virtual visits, they would not be able to care for their children. What home visitors found is parents are more than capable and more than able in a crisis and in non-crisis to care for their children. The screenings, the well baby visits that might be virtual, parents have really taken it on and done all of that work while keeping the families together. And so we have to be mindful of having relationships with parents and not transactional episodes of let me ask you a survey or let me do a focus group with them, but really joining their table and inviting them to your table and then making a table with them and having a true relationship to understand what they want, when they want, how they want it, and to co-design a lot of the strategies. I want to also lift up one issue They said I could talk about anything I wanted, so I will. I wanted to put on the radar screen, I think, an exciting development that I never thought would happen that might happen in our lifetime. And I think it's really instructive for every health and early child advocate to know about. There has been an organic movement happening right now to study and examine present-day impacts of genocide against Indigenous people, slavery, Jim Crow, systemic racism against Blacks, as well as others, and a real reckoning, a racial reckoning, I think that Myra mentioned. I think that is so important to change and reshape the narrative of how families came to have disparities, right? And really filling in that information. There's a movement for reparations, to study reparations and to see what we might do on a more systemic scale for wealth inequality. And we've seen this in Providence, Rhode Island, Evanston, Illinois, Asheville, North Carolina, and certainly in the state of California, where the legislature was considering a commission. I think it's really important to address wealth inequality, but also what we've been talking about here for health transformation is a form of reparations. It is to repair. And I think early childhood programs are really race equity accelerators that we should really be lifting up in the context of all of these different efforts to repair and reconcile and come to a reckoning with our nation's history and what we want going forward for children and families and for our nation. I'm going to stop there and turn it over to Joan. I'm so happy I didn't have to follow Joan because she's so phenomenal, but I've had to follow all the other phenomenal speakers, which is hard to do as well. Joan, I'm turning it over to you.
You are phenomenal. I feel like we all should breathe a second because there have been gems of things said here. I've been trying to write them and I don't think I've captured them. I'll have to listen again. I want to start by acknowledging all of those speakers because every single one of them is making such an enormous contribution. And I'll specifically call out Karen for her amazing work at the Alliance. It made my heart happy, Karen, for your contribution. You know, I've watched the Alliance, as you know, from day one and watched its growth, and it's people like you that have made it successful and all the amazing advocates. So thank you, and thank you for those very powerful words, all of you. And I love that you and Myra kind of echoed similar themes. Look, it's hard now. Let's be honest with each other. It's a tough time. They asked us to speak about policy opportunities. You know, it all depends on what happens in 40 days. And very little I can say beyond that, except for get out the vote. And I'll leave it there. But I do think that, you know, when Karen talked about a reckoning, we are at a point of reckoning. Either we keep our democracy or we don't. And so I think we all have to take it very, 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 very seriously. I'm going to try to talk a little bit about health and the topic here and not just get onto the political bandwagon, although it's hard not to right now. What is exciting is that we're finally starting to see a broader definition of health. Unfortunately, I do think it's still in most people's minds the absence of disease. So we've got a long way to go to get that idea that child health and early education, that they're all the same science, that they're all the same thing. It's about child development and child well-being. But I still think we have a long way to go. What I want you to know, because I do so much international work, is this is not a conversation in the United States. It's a conversation that's being held all over the world about how we bring these worlds together, particularly how we recreate child protection. And in US language, that's recreating child welfare, which talk about what something that needs to be addressed regarding structural racism. We can start with that system. And I know Karen's taught me a lot about that. So this conversation about thinking about a prevention system is really at the heart of what we're talking about in transformational health. It's bringing that together and, and having the difference, I think, in what I see here and what I see around the world is in many countries, even much poorer countries, they have a public health system. If there's anything that's COVID has shown us is we don't have a public health system that's universally accessible. And that is one of the difficulties. Yes, we do think we have to start the infant agenda with health. And I would say we have to start it with the disparities in maternal mortality, the fact that Black women are dying at three times the rate. That's how equity starts there. But I do think that, we have some structural problems that we don't have the systems even to build on. That said, I want to go back to what Myra said about we have to be deliberate and we have the tools. Absolutely. I mean, how many decades? This is my 5th decade, folks. 5th. That's 50 in 21. How many years do we have to know that 1 out of 3 Black children, 1 out of 4 Latino children are in poverty? And it's really only 1 out of 11 around white children, and that's still too high. But we have known these figures over and over and over again. I was telling somebody the other day that I had this project going. I'm cleaning my basement, and I'm pulling all the reports that I've had for decades piling up down there that started actually in 1972. And I could change the cover, and say the same thing. So I'm getting impatient, and I want you to be impatient. I want you to be impatient. No, and that is what John Lewis taught us. I mean, he taught us to be impatient and to be courageous. What we are seeing in the RAPID study is really, and if you haven't been following the RAPID study, that's 1,000 parents a week that have been answering this survey since April 6th, is this chain of hardship that families are facing, not just families in poverty. This week we're showing even middle and upper income families, Black and Latino families income is not a protection for them finding material hardships. So what we're seeing is that material hardships, and we have to give it voice, and that's what the study is all about. There's something that's coming through this conversation about community that I think we need to pay attention to. Yes, I've spent my whole life at the federal level mainly, even though I started as a community in the communities and community action years ago, decades ago, and that was what I actually learned more there than any other time in my life. But I think that when I talk to people around the world, I remember in the early days of the COVID response, I was talking to these people that had worked on the Ebola crisis in Sierra Leone. And then I talked to some friends that I have in Italy through the crisis in the beginning. They both were saying the same thing. In places where you had a strong community, where people knew how to come together before the pandemic, you had a better response. So part of our preparation for the next crisis and for addressing this is doing what we've heard repeatedly throughout this conversation, which is building back better, starting with our communities and starting with not an assumption of what we think families need, but by asking them what they need, by believing that there are assets in every poor community. Poor communities have assets that we should build on, and that's a very important message. I could go on and on, but I'm going to end with one, besides vote. I'm going to say one thing about evidence, because Charlie said I'm a big believer in evidence. This is my new line about that. You don't need evidence to know that children have a basic right to health. You don't need evidence to know that children have a basic right to good quality childcare. So we have to get over that and really join the rest of the children's movement around the world that says children have basic rights. And so what I'm hoping in the next administration is children's policy, and I thank First Focus for raising the visibility of this issue. Children's policy comes to the top of the agenda as a right. And then we use evidence to figure out how we deliver services better. But we start with children's rights, and we keep our impatience, and we vote. That's it.
Well, thank you very much, Joan, and I hope you can hear me. Since Joan is a tough act to follow, and all of the presenters are tough acts to follow, I'm not going to attempt to do that. There are a couple more slides that we have in our pack, and we will make all of these slides available to you, as well as the full recording on our website. The very last slide is one that we have used in all of our presentations, and it really is that call for us, and I think you heard it from everyone who presented, is that we do know enough to act. We don't know everything we need to know, and we need to continue to learn, but we can achieve collective impact if we really do engage in collective advocacy. So this is the sixth and concluding webinar in our series that we did this year, but we're going to continue to work and do so much more with InCK marks around how do we provide the education and the communications and that venue for collective advocacy around child health care transformation and around the broader issues around child health care transformation, contributing to what we know our children deserve and what we need to do. So I really want to thank all of the people on the panel, and I apologize for going over a little and for the glitches that we had technologically, but it showed that we all could adapt moderately well, and look forward to continue to connect up with you who are out there in the field doing this work, so that we really do build the base of support for getting children and families what they need, and in that targeted, universalistic approach in ways that improve the prosperity for our communities as a whole by really rectifying inequities and dismantling racism and its impacts upon kids. So thank you very much.
Excellent. Bye, everybody.